Thank you for inviting me for this meeting. This is my first time here again. When Dhoble called me, this was a couple months ago, asking me to speak, I'm like, fine. Then he sent me the topic, talk something about ice. I'm like, can you give me some more exciting topic? Probably maybe for the next time, but this time you talk about ice. And this morning, he sent a text saying that please limit it to 7 minutes, but talk about all the clinical scenarios that you can think of. I'm like, okay. So with that, I'm going to start, and if I'm too fast, please stop me. And this is all Dhoble's fault if I go too fast. So these are my disclosures. I think it's very important to talk about evolution of ice and the indications of ice, the usage of ice, in parallel to the innovation that happened in the structural heart field. So, as we had a great talk about Watchmans and the amulets earlier, we started LAAO with Watchman 2.5. This was primitive device with a lot of leaks and a lot of device-related thrombus, and we evolved from that to Flex, to the Flex Pro, and along the line came Amulet in 2022. Similarly, there was some advancement from 2D TE to the 3D TE, then to the 4D, which is a time dynamic TE, with the new software packages along with that. Then came the MitraClip, the TriClip. MitraClip evolved from first generation to the fifth generation. We have G5 now. In fact, we just did a case earlier this week, and then alongside also came the Pascal. This all required evolution of the imaging because all these procedures are imaging related. However, I must say that initially, the 3D ice use was very limited in any of these procedures because these procedures did not exist back in 2014 and 15. MitraClip was very early on. The TriClip did not exist. And in fact, when we did the first study for the 3D ice was in the patients with TAVR. So Siemens offered us 18 catheters to kind of do a piloted study, and we did that in the era of general anesthesia while doing the TAVR. We put this patient under moderate sedation, use the ice only to look for any effusions or paravalvular leak, and we found that ice was very useful. There were 3 patients that had significant PVL that we post-dilated afterwards, and we had very limited knowledge. We had very limited views that we could work with. This was an 11 French sheath, so imagine in the era of partner 2 with big 22 French sheath along with this large venous sheath. But we thought that this ice was really useful in that case, but then after that, it went blank. Because TAVR evolved with the minimalistic approach, conscious sedation, transthoracic, echo, and things like that, and then ice went, disappeared. We saw some reports, from some institutions, but nothing substantial. And then, alongside when it was blank, it was not existent for actual clinical practice, there was a huge research and innovation going on the 4D and 3D ice spectrum. And what we saw and what we see today, this is mind-boggling, the images and the usefulness of ice in these procedures. So today we have 3 options with the 4D ice. One is the Siemens, AccuNav, the Biosense Webster, and the Philips VeriSight. They all have its advantages and disadvantages. None has been superior to the other. Some offer some software packages. Philips you can use along with the TEE on the same machine at the same time. So they have all been used in different clinical scenarios. These are the French sizes or the vessel sizes that you need. So you need 12.5 for one all the way to 9 French for the Philips one. This is just one aspect of why 3D ice is much, much better than the 2D because it provides you with this omniplane 3-dimensional structure. You have the ice crystal arrangement in 45, from minus 45 to plus 45 degrees, so you can rotate the crystal with the knobs that you have on the ice catheter. And these are just the advantages. I'm not going to go over that because I see there is only 2 minutes left. Anyway, so I'll go each scenario and then probably talk about it for a couple of minutes. So the use of 4D ice in LAAO, very useful. And you can see that you can start the procedure right from the transeptal, and a lot of electrophysiology folks use ice predominantly for the transeptal, even when they have TE available. So go figure. This is once you have the transeptal puncture either with the ice or with the TE, And this is, I'm showing this case, this was early on our experience, I was using both, I still use both. I haven't matured to ice only, but you can see once you do the transseptal puncture, you can just follow that ice catheter alongside of the wire into the left atrium. You don't need a separate transseptal puncture for that. And then once you're in the left atrium, you do your measurement just like how you do with the TE. And now from this point on is predominantly ice-based LAO. You take your pictures, you see the ice and the Watchman sheath is going through the same transseptal puncture. You deploy the device under ice. They look very identical, probably better than the TE images because you're looking right at it. And then you do your regular assessment. You can release the device. You don't need TE for any of that. You can do all of this under ice. And these are the images post-deployment. You can do whichever angle or whatever cropping type that you need. You can crop it, measure it, and then go forward with that. What's the clinical evidence behind ICE? There are only a handful of studies that have proven safety and efficacy for ICE-guided LAAO. I'm only going to talk about two very briefly. So this was the NCDR LAAO registry. The incidence of ICE-only LAAO is 6%. 14% use both ICE and TE, but as you can see, predominantly 80% use TE only. The finding from this large NCDR registry was that ICE was associated with significant higher rates of pericardial effusion. Again, this was early on. There was no protocols existent. Most of them were done probably with the older probes. However, they both had TE and ICE. They both had higher rates of complete LAO. So efficacy is there. Safety was a concern. Then this was a prospective 100-patient study that was done to assess the feasibility and safety of ICE-only guided LAAO. And they used the ICE VeriSight Pro probe, which is made by the Philips, which is 9 French. And that study proved that the LAAO with Watchman Flex using a simplified imaging protocol was both safe and effective. Moving on to the 4D ICE use in T-tier. This is where I use ICE most of the time. And there is certainly an advantage of ICE over TE because your ICE probe is directly looking at the tricuspid apparatus leaflet versus the TE, it has traversed long distance. Some of the advantages, nowadays we get a lot of these referrals for tricuspid regurgitation. They already have a lot of hardware in their heart. Almost half of them have either pacemaker or ICD. Majority of the others have either either transcatheter aortic valve or some kind of surgical valve, or even mitral clips. It causes a lot of refraction of the ultrasound. So in this scenario, ICE is really useful for the tricuspid intervention. This is one of the patients video. You can see there is severe TR there, but when we're trying to get the perpendicular arrangement of the triclip on the tricuspid leaflet, you just could not get it. And then we inserted the ICE here, a couple things, maneuvers, and you can see clearly the leaflets are falling onto the triclip. There is no question about that. Made us more comfortable closing the clip, which is what we did. We put the grippers down there. We closed the clip. And then after closing, the TR is substantially lower. We release the clip, and these are the final pictures. You have to do some minor ICE manipulations to get the pictures that you want. Sometimes you have to put it close to the tricuspid apparatus, all the way flex down into the tricuspid annulus. And these are the final result. As you can see, ICE images are no different than the TE images. In fact, the ICE images look even better, some might argue. Similarly, for the TTVR, ICE has been a big help. As you can see in this patient had prior mitral surgical valve, then valve-in-valve. There's a lot of refraction from the TE because it was directly in the way, and we had to put the ICE there. And now you can see the tricuspid leaflets falling in onto the ventricular anchors of the evoke valve there. Sometimes, as I said, sometimes you have to take this, aggressive maneuver. So in this case, we had to put the ICE probe, bend it backward. It's called reverse Candy maneuver. So you're kind of looking at the tricuspid valve, making sure that you have the appropriate leaflet engagement there. And then these are the final images. You release it. You can see the leaflet. You can do all kinds of interrogations using the ICE catheter there for the TTVR. And just a couple more examples. This is another application of 4D eyes. So I routinely use this one even for the ASD and PFO closure, not because it's superior to 2D eyes for the PFO closure, but it also kind of gives you a little bit of teaching, and you can learn from the eyes usage in these simple cases. And the images are beautiful. You can get the biplane. You don't have to go look for the aortic rim coverage or the posterior rim coverage. And this is another example for the transcatheter pulmonic valve replacement, where you can directly look at the pulmonic valve right immediately after. So these are just the examples to show that there is wide applicability of ICE in various structural heart intervention. I think this field is moving now faster than the innovation in the valves and the other tier devices. And there is a huge need for that. So my simplistic approach to 4D ICE is that whenever I use it, I use 3D capabilities, including biplane. Even if you don't take the 3D volume, I'll always biplane it so it minimizes the need to go and look for different things. Always get off the 90 degree while using biplane. Catheter position, there is no ideal position for any of the ICE maneuvers. You just get it in a position where you have the best line of sight for the structure that you're looking for. And optimizing 3D is similar to TE. The key is to get the best two-dimensional images and then go optimize that and opt in the full volume and then analyze that. So ICE in structural heart intervention, where we stand today, there is a big move towards improved and protocolized imaging. So if you ask, for example, Philips or Siemens, they have the protocols that you can use to ICE-only LAO or ICE-only tier. Total ICE-guided LAO with the nurse-led sedation is on the rise, and I can vouch that many of my colleagues and friends, not just in the city, but around the world, they're moving towards this. Adjunctive imaging tool for the tricuspid intervention is very useful to use ICE. In fact, some might argue that people you can even perhaps try to move to ICE-only tricuspid tier procedures because of the resolution of the images that you get. One thing that we still struggle with, and we, as physicians, as interventional cardiologists, and as a societies, trying to push for higher compensation for the procedural imagers, because they're the one who are doing all this cropping. You're just putting the ICE catheter in the heart and manipulating a little bit, but people like Amit and Deepa, for me, they do all the imaging magic. So there is a higher push for higher compensation for procedural imagers. Thank you so much, and with that, I'll stop. I know I'm 6 minutes over, Dhoble, but I'm sorry.